So they could have a pre-existing dissection of an artery, which doesn't have to be traumatic. It can be non-traumatic. Or they could have the very early stages of the presentation of a stroke. Okay, so that's the first part. And then the second part is recognizing that we need to probably look at different examination strategies. And we've written about this, I've written about this with various authors over the years. If someone's got headache and neck pain, I think one of the first go-to areas is that we've most certainly got to look at assessing the cranial nerves. Because in every other area of the body, if we suspect someone's got a neural involvement in the lower limb, if we suspect someone's got a neural involvement in the upper limb, we'll only do that based on symptoms. And the symptoms most likely that will lead us to that are tingling, pins and needles, and maybe some motor dysfunction. Weirdly and strangely, I don't know what it's like where you did your training, but certainly over here in the UK, we don't think the same way about the symptoms that go upwards towards the head and neck. And there's been a reluctance for some reason for cranial nerves to be taught and for cranial nerve testing to be performed. And I've always puzzled over why that is. But based on the fact that if someone has got these symptoms affecting the head and neck, we've got a fairly high risk situation. The question for me is, why wouldn't you assess the cranial nerves? Because it seems like a really logical thing to do, the same way that you would assess the lower limb nerves and the upper limb nerves if you had that suspicion. The only difference is this is a much more serious affair, because if we do have a problem with the vascular system and maybe the cranial nerves combined, then this could be the development of a serious condition.